I'm pleased to introduce Ms. Kathleen Keane, PhD RN, who will be presenting today's topic. She's been working at Maine Med since 1995 in a variety of roles. She currently works as both a VAD coordinator, a heart failure education nurse, nursing unit-based educator, clinical nurse, and VAD resource RN. Whew, it's a lot of stuff. She's certified as a clinical nurse lead, critical care registered nurse, and a BLS instructor. And she's also working on her heart failure certification. She has numerous publications and presentations to her name. Of interest, Kathleen worked in the Peace Corps in Zinder, Nigeria from 83 to 86. Welcome, and thanks so much for sharing your time and knowledge with our staff. Kathleen, they're all yours.
Thank you so much. And I really appreciate everybody being here today. I have one question, Rob. Is my right side of the screen their right side of the screen? If I say
yes, yep.
Okay. So one correction, I'm not a unit-based educator anymore, but that kind of got me into this job of being a VAD coordinator. So I sounded like Superwoman in the intro, and I'm definitely not. I appreciate the chance to do this talk because it helps me review my practice and think about my practice and reflect upon it and learn more. I'm going to talk today about LVAD devices, or left ventricular assist devices. You can see there's pictures here, and these are pictures for your information about the three main devices we have right now. The HeartMate 3 is the one I'm really going to focus on most in this talk because that's the one we're currently implanting. But these other two you will see out there, and so I will highlight them and contrast them or point out similarities between the HeartMate 3. The first generation pump is the HeartMate 2 over here, and I will discuss that also. I'm going to try to highlight some clinical pearls for you, in your practice that I've kind of found along the way that helped me caring for the LVAD patients. I don't have any disclaimers, and I put some information about our team. We have a really great team here. There have been a couple different iterations of our program here at Maine Med, but this one is really wonderful because it's multidisciplinary. So we have a surgical director and a medical director of our program. We have 2 excellent surgeons. We have 6 advanced heart failure physicians that focus, that know very well these VAD patients and transplant patients. We implant LVADs here, but we do not do heart transplants. However, we work with patients who have had heart transplants. Some of those are patients who had LVADs and were met their goal of getting a heart transplant. So we will still manage those with Boston centers like Tufts, Mass General, and the Brigham. And then there's 4 of us VAD coordinators, and they're awesome. Everybody brings their own expertise to their role. And I want to highlight that we do have palliative care team, which is a physician and a social worker who are involved with our patients from the beginning. So I'm going to chunk out things a little bit today instead of just kind of hitting you with tons of information and going all the way to the end, so that we can sort of pause after we cover a certain amount of material and hopefully answer some questions and clarify any information that you need clarified. We're going to cover these objectives. What is an LVAD, or a left ventricular assist device? How does the LVAD work? Who is an LVAD for, and why would someone need an LVAD? So I have a short video which I'm going to play for you, and then we can, I'm not going to speak during it, but we can discuss it afterwards.
Heart failure is one of the biggest problems of mankind.
The technology has progressed so far that you can basically bring someone back from the brink of death.
It's really a life-changing technology.
The potential for how many people with heart failure could be impacted and helped is massive. It is one of the most common diseases that we face. arguably one of the #1 causes of death. Heart failure just basically means that you're not getting enough blood flow to your body. It gets to the point where you can have sudden death.
My journey with heart failure started with our 3rd pregnancy.
She couldn't eat, she couldn't walk, she could not function at all.
There's really only about 3,000 hearts every year for transplant. This shortage of hearts for people with advanced heart failure is only going to get worse. Some form of a mechanical substitute for a heart, a left ventricular assist device. They make up for that deficit. It's a mechanical heart pump that's attached to the heart to help overcome its inability to pump blood to the rest of the body.
Here at this Zurich site, we do R&D and manufacturing for HeartMate 3.
Yeah, it's great working with Andy. He's been here for 20 years.
We have several interests which are very similar.
Nature is really close. Every now and then we'll go mountain biking over lunchtime.
So in the very early days, these devices look like this one. It's a pump that has a membrane in it. In other devices, you would generate some friction.
Human blood is very delicate. The cells might get damaged.
And when that happens, you basically have a pump that has a risk of an adverse event, like a stroke.
There were challenges to shrink it down to the size and getting the rotor stabilized. Parts became smaller, much more powerful. In 2000 or so, we brought this electronic from that size into an implantable. In the HeartMate 3, we apply the right amount of magnetic forces. The gap between the rotor part, so the thing that turns and the thing that stays in place, is all around the rotors. They do not contact each other. This is the perfect scenario for blood cells. And this can only be achieved if you use the full maglev technology.
In these pumps, you don't see the clot formation that you did with older generation pumps. It is now comparable to a heart transplant.
As I sit here with you today, I am 3.5 months post-LVAD HeartMate 3 surgery. The kids, they're noticing as mommy gets stronger, and they'll say things about, mommy's able to do more, and they see it. They're just watching pretty much a miracle play out.
It was amazing to see the device that you've worked on for so long actually being used, and now it's helping thousands of people.
In a word, I would describe my life as having hope.
It's science, but it looks a little magical. I think that's the beauty of the thing.
So you could see that was actually kind of a promo spot from Abbott, which makes the HeartMate 3 and also made the HeartMate 2. There's a couple things I just want to mention about that. You'll notice the heart was beating with the pump in it. And so the heart is still beating when it has a LVAD in.
Hey, Kathleen, could I launch that poll? I realized I didn't do it before we started.
Oh yeah, sorry, forgot about it too.
Yeah.
Yeah, sure.
So guys,
Do it.
this is an anonymous poll. It's just to kind of gauge your understanding of and try to have you start thinking a little bit about what a VAD is. It's totally okay if you don't know the answers. It's just three questions, multiple choice. And again, just to kind of get you thinking a little bit about what the VAD is and what it requires. We'll share the results with you all. So for question number 1, should you be able to expect to palpate a pulse for a patient with a VAD, yes or no? And will a pulse oximeter register on a patient with a VAD, yes or no? And Kathleen, feel free to chime in here. But the answer that we were leading towards, and it seems like the consensus is generally, yes, you should be able to palpate a pulse, but not always. And will a pulse oximeter register on a patient with a VAD, even if they're apulsatile? In Kathleen's experience and from what we've discussed, yes, you can actually use a pulse oximeter on them. What equipment do you need? Question number 2, select all that apply. So the equipment that you need would be a manual BP cuff or an automatic BP cuff and a Doppler. You do not actually need a stethoscope in this case because you use the Doppler to auscultate for that the mean arterial pressure. So question number 3, what is the targeted mean arterial pressure for a patient with a VAD, and at what mean arterial pressure should you notify the VAD team? So it looks like, again, the majority of people got it right. Well done. And the answer is 60 to 80 millimeters of mercury. Anything greater or lesser than that, you should notify the VAD team. Great. Go ahead there, Kathleen. All set. Thank you.
Okay, thanks. Yeah, we're going to go over and cover that information in this talk. So it's with these patients, it is challenging because you want a hard and fast rule, and sometimes you have to be a bit of a detective to figure things out with these patients. I just wanted to talk about normal blood flow in the heart first. And this helps us understand what an LVAD does and who it will work for and who it won't work for. So normal blood flow in the heart is deoxygenated blood coming into the right atrium, and it's going through the tricuspid valve into the right ventricle. And you can see in this illustration that the right side of the heart is a thin-walled ventricle, okay? And then that right side of the heart is pumping blood to the lungs via the pulmonary artery, which is kind of a unique artery in the human body because it transports deoxygenated blood. The blood then returns from the lungs oxygenated into the left atrium, and from there into the left ventricle. And when a heart beats, it ejects blood from the left ventricle through the aortic valve into the aorta, okay? So the left side ejects through the aortic valve into the aorta. The right side ejects through the pulmonic valve into the pulmonary artery. So I think of the right side, it helps me to think of it as a low pressure system. And I think as of the left, did I say right side? I meant right side. The left side is a high pressure system. And you can see this in the illustration because the walls of the ventricle in this are very thick, okay? And that's because the left side has to eject blood against the systemic vascular resistance of the whole arterial bed of the body, right? So it's really got to have some force behind it. Whereas the right side only really has to eject against a very low pressure system, which is the lungs. All right, so I find it really helpful almost to think of those two pumping systems separately because they're so very different, yet they work in conjunction, right? So an LVAD is only on the left side of the heart, and it's implanted in the apex of the left ventricle. And believe it or not, in the human heart, there's a little dimple there that you can almost feel, that's what the surgeons tell me, where they pass the cannula from the LVAD into the left ventricle, and they do core out some of the heart. And so my point there is that there is nothing on the right side to help the right side. And so a lot of what we do with these patients is be very protective of the right side of the heart. This is another short video that I thought is a good illustration of heart failure.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
So with that knowledge about how a normal heart works or how a heart with heart failure deals with trying to pump blood, an LVAD is basically implanted in the left side of the heart to help decompress the left ventricle, take blood, and pump it up to the aorta. And the reason I just like this picture is because it shows how the conduit, or this is called the outflow graft of the pump, is attached to the aorta. So normal blood flow, blood would be coming into the left ventricle, out the through the aortic valve and into the systemic vasculature. But with an LVAD, in addition to the normal blood flow, which you may have, you have this pump taking blood and basically very efficiently pumping it up and into the aorta. It decompresses the left ventricle so that it can, what we call, reverse remodel, because in heart failure, what can happen is the tissue of the heart gets so boggy, the architecture of it actually falls apart, and the pumping ability of the heart worsens and worsens and worsens, and we call that remodeling. With reverse remodeling, the pump can actually help some of that architecture heal itself and get more organized, so it pumps better. We talk about ejection fractions of patients. That's the percentage of blood that's ejected with the left ventricle, and a lot of our patients have ejection fractions of 10%. We're normal 55 to 60%, right? So this pump is doing a lot for the person. The one important point is it is dependent on flow from the right side. So once again, we're very protective of the right side of the heart. If you have acute right heart failure, you are not a candidate for an LVAD. You would need possibly an RVAD and an LVAD, which is called a BiVAD, okay? And you would go to Boston. That's where we refer to, because we don't implant those here. This is just an illustration of the HeartMate 3, how it works, and I think it is helpful to see this. This is the device that most people, I think, are going to have.
HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium. A small electric motor inside the HeartMate 3 drives the pump, providing blood flow similar to a healthy heart. Although the HeartMate 3 LVAD is virtually silent, it is normal to sometimes feel the pump working. To power the pump, a tube called the driveline passes from the LVAD through the skin in your abdomen. The driveline consists of two cables, the pump cable and the modular cable. One end of the pump cable is connected to the pump, the other end exits your body. The modular cable connects to the pump cable at the modular inline connector, and the other end connects to the system controller.
So the HeartMate 3 is really the standard of care for implanting pumps right now, but there is another pump out there very similar, not quite as good, I would say, as a HeartMate 3, which is called the HVAD, or Heartwear LVAD. And so I'm just showing you a picture of it because you can see it looks very similar to the HeartMate 3. But it is not frictionless. The HeartMate 3 has that little bobbin that's suspended in the pump. This has contact points, so the stroke rates are higher for these patients. And that's one of the really dreaded complications of having a heart pump. One of the ways I just want to mention that we match having the pump work for the heart is by doing an echocardiogram and adjusting the pump speed to how we see it's working with the heart. So that's a very common, that's our way of really matching the pump to the heart. I did really want to show you this animation of the HeartMate 2 because it works totally differently from the HeartMate 3. Even though the peripherals on it, like the controller and the batteries, look very, very similar. So how would you know which pump your patient has? You would ask them, but also the controller, which we'll talk about more, that's the little computer that runs the pump, it will say which device it is.
The HeartMate 2 is a small and quiet advanced blood pump designed for improved outcomes with a wide range of late-stage heart failure patients in need of reliable, long-term circulatory support. 60% smaller than currently approved implanted electric pulsatile LVADs and weighing only 400 grams, the HeartMate 2 incorporates precision engineering, a simple design, and 30 years of clinical experience. It is intended for long-term support as a bridge to transplant or for permanent implant known as destination therapy. The external system components of the HeartMate 2 include a small, flexible percutaneous cable that provides power to the pump and is designed to accommodate patient activity, the system controller, which controls pump operation, and the batteries, which may be conveniently worn in holsters and enable the patient to resume normal daily activities.
So you can see that pump works very differently. And the pump itself is actually not in the heart, it's in the pocket below the diaphragm on the patient. So completely different way of working. It's a good pump. It was the first generation pump, but there's much better pumps now, so they're not implanting those anymore. This is just an outline of the basic equipment you might see with a patient who has an LVAD. So this part is internal, where the pump is in the person, and this is internal too. This is called the drive line. Some patients call it their lifeline, and I encourage them to call it that because that's what's running the pump, and if it gets damaged, the pump could stop. There is actually a modular drive line, which means there's a disconnect point here. If for some reason this part of the drive line got damaged and we needed to change it out, we wouldn't have to replace the whole pump. And this is the computer that is running the pump, and it's called a pocket controller. It's really the brains of the operation, and it runs with 2 power cords, and it runs to 2 batteries or AC power. So at night, you would see the patient would plug into this, it's down at the bottom here on the left, a mobile power unit. And we recommend that. We don't recommend people sleep with their batteries because it's possible for people to sleep through some pretty bad alarms. And I'm going to demonstrate alarms for you later and let you know some patients have slept through that. So we don't want people to fall asleep, have their batteries drained down, and then get a critical battery alarm, which has happened. All this stuff has happened, and usually the patients do okay, but it's just scary. So who's an LVAD for? So it's for people who have systolic heart failure, a reduced ejection fraction, and usually less than 30%, okay? And it's really for the left side of the heart, not the right. And so we do a very careful workup. We do a lot of work to figure out, is an LVAD gonna be good for this person? If they have some kind of restrictive cardiomyopathy, an LVAD won't help them. And so what we usually do is work with a transplant center to get them listed for transplant, if that's what they want. So who might need a heart pump? So people with dilated cardiomyopathies, and it's a whole range of people from young to old. We have people who around pregnancy get what's called peripartum cardiomyopathies and develop heart failure. Idiopathic cardiomyopathies, it runs in a family. For some reason, they develop heart failure. And we've had a young woman who that happened to. And her, it's just devastating. One of her sisters died from sudden cardiac death before all this was known. Ischemic heart disease causes a cardiomyopathy. Post-heart attack can cause remodeling of the heart, the scarring, the architecture changes, that can cause heart failure. So there's all these different causes. Sarcoidosis, that's another kind of, I think of it as like a weird one. It's a connective tissue disease. People with substance use issues, alcohol and other drugs. So toxins for the heart would cause that. And so a patient that presents with a heart failure, sometimes they've been dealing with heart failure for 30 years. And now it's time like where they're thinking about getting a heart pump. right? Or it's an acute viral myocarditis and they're 25 years old and they've never even heard the words heart failure. So it can be a whole range of people who have these devices. Some patients who are older and or are not candidates for a heart transplant elect to have the LVAD put in and then have no further therapies after that. So they're going to live and die with the pump in. And that's why we have palliative care involved from the very beginning with these patients. We're very careful to identify their goals of care. Some patients are candidates for a heart transplant and want one. And so we work with them to get them listed at one of the centers, usually in Boston. Very rarely will a patient recover heart function with an LVAD and be able to have the LVAD taken out and be okay. They're still not really okay if that happens. They still need to be a heart failure patient. But we don't really present that as an option to patients because it's extremely rare. And we don't want to really get their hopes up for something that really isn't realistic. So this is where I'm going to pause. These were the initial objectives for this chunk of information, and I just wanted to see what questions there are and if I can clarify some concepts for people. I'll just share a story about a patient, one of our first patients with our new kind of iteration of our program, who the first time I met him, he was our first implant, and I was a little nervous because I hadn't worked with a heart pump patient for a while. These new pumps are amazing. They're really, really different. If any of you have worked with the older pumps that are even external to the patient, these are really different, amazing pieces of technology. But when I met him, I introduced myself and he introduced himself and he said, "Hi," and then he said his name and he said, "I don't have a pulse." That was the next thing he said. And, it reflects a lot of anxiety that these people feel because they're like, what is with my heart now, right? And so we ended up talking to him, and I think he thought that his heart was just sitting there in his chest, not doing anything. And so we ended up talking to him, and we ended up putting a stethoscope on him and letting him listen to the pump, but also listen to his heartbeat. Initially in an implant, it can be hard to hear heart sounds, but usually you can hear heart sounds if you auscultate on the right side of the chest. And so we kind of helped him kind of come to grips, like, no, your heart is beating. It's doing some work. And indeed, sometimes if the pump stops for some reason, it doesn't automatically mean someone's going to die. They may get dizzy, pass out, but they may not. They may be awake. So the heart is still ejecting blood through the aortic valve. And we don't want it to be doing that a lot, but we like that blood flow to continue, that normal blood flow, so that there's no clot formation on the aortic valve and so that the leaflets of the aortic valve don't fuse. So I don't know if, it's kind of a crazy concept to wrap your head around, but you have two ways of getting blood flow to your body.
Great. Kathleen, we have 3 questions that have come in. First one is from Karen A. When someone is end of life / hospice care, at what point is the LVAD turned off?
So we have palliative care involved and we identify the goals of care. And I would just say, generally speaking, it's when the patient is obtunded and totally unconscious that the pump is turned off. And this is a very careful process that we do with patients. If they, usually they start to fail, there's some issues that come up that aren't getting better and they feel, it's a struggle. Like if they develop worsening right heart failure or incessant GI bleeds. Some people, if they do have an ICD, not all these patients do, elect to get that turned off. And then we have had some patients go to Gosnell House, and they've been just so wonderful with our patients and families, because oftentimes the families will discuss with palliative care very frankly, what is going to happen when they do comfort care only, it is comfort care. And when the patient is treated for pain, if they become more somnolent over time, they're much, much less responsive. So once the patient is really unconscious, the decision is really up to the family when they feel ready. And this has all been discussed. Nonetheless, it's difficult because we want them to feel comfortable with the decision. And we want to be responsive to when they want it. So, we will have a plan for the patient, and you can see it coming with a patient. So that's a good question.
Next question was it's actually, well, I'll say a two-part question from VNDAD1. Is it difficult to obtain insurance approval? And how many of these have roughly been implanted to date?
Yes, I would guess, so we do get patients who don't have insurance that need a heart pump, and our team and care management at the hospital work very hard to get patients Maine care. It's not hard to get the insurance approval if they're a candidate. We do have to go through all those processes though to get the Maine care. So our very first patient had no insurance. And so we work to get the patient resources. What was the second part of that? Sorry.
Roughly how many have been implanted?
Oh, yeah. Some of our patients have gone on to transplant. So I am guessing around 40.
Okay.
We have about 30 patients now, but and these are raw numbers for the program that
this is in Maine specifically, yes?
Yeah, specifically in Maine, yeah.
Okay. Roughly average length of life after an LVAD is initiated for someone who doesn't want to transplant, so for destination therapy.
Right. We have had patients that have had their LVADs currently for 5 years right now. So kind of when I started working with the program, they talk about some patients having their device for 10 years. The DT patients, which is destination therapy, what happens is it's not so much that they start to get more complications. So initially, the first few years, things are pretty steady state, but over time, what will happen is they'll start getting repeat GI bleeds. And those can be really devastating. And it's part of the body's response to the pump, because the pump is continuous flow. It's not beating like a heart. So the body's response is to kind of make these almost AVMs, these sort of dilated blood vessels, and people's GI tracts bleed, their nose bleeds. It's pretty tough. So bleeding, stroke over time. These patients are on warfarin, and there's always a risk of hemorrhagic stroke and thrombosis. Right heart failure can be an issue. One very serious complication is aortic insufficiency. And because we had a patient that happened to, we tried to fix it surgically, and she unfortunately passed away. And the reason that's so bad is because what happens is the pump is pumping, but because the aortic valve is totally wide open, the blood is just doing a circle between going from the left ventricle into the pump, going up into the aorta, and then because the aortic valve is open, it gets sucked right back through the heart again. It's doing a little circle in the heart. It's not getting to the whole body, right? So that's pretty devastating. We've only had that happen once, but we do a careful workup of the valves. So I guess I would say 5 to 10 years, but you can expect that more complications with time. And if the goal is transplant, we really hope to use the pump as a bridge to transplant. We want to get them on that transplant list and get them their heart.
Okay, great, thank you. And the last question, I think you'll touch a bit on this in future slides. Are typical medications diuretics and thrombolytics for managing these patients?
Yeah, so
Jenny.
they're all the basic heart failure medications that you would use. So diuretics for preload reduction, because we're trying to protect the right side of the heart. Anticoagulation, we don't usually use thrombolytics, though we have in an acute situation, if someone looks like they're getting a clot on their pump, which is always a risk. But after load reduction with things like hydralazine, isosorbide, ACE inhibitors, if their kidney function is okay, ARBs, if their kidney function is okay, Entresto, if their kidney function is okay. So, yeah.
Great, that's it for now.
Okay. This is the next chunk of information that I was going to go over. We'll talk about the key safety measures when caring for these patients. I'll discuss them, but we do not advocate any chest compressions unless one of our doctors says to do chest compressions on a patient. Other than that, ACLS can be followed. But even in the hospital, we don't do chest compressions on a patient. And the reason is that very rarely is it the pump that's the problem. Okay, usually it's something with the patient, like they're in VT or VFib, or they're bleeding, or they're super dehydrated. So doing CPR could dislodge the pump and then cause a whole nother problem besides the really original problem, which is much more likely. So unless the doctor says to us, do chest compressions, we don't. And I'm going to go into each of these a little bit, but stabilizing the drive line, water, we don't want to get water near the device. They can't get their dressing wet. And we'll talk more about the dressing. It's a magnet in the pump, so staying away from it, absolutely no MRIs. But also, like, we have a lot of Maine men who have like heavy equipment. The company does not recommend that they're operating heavy equipment or doing things like welding. You'd be surprised what people come up with. Chainsaws, not a great idea if you have this heart pump, because also your drive line could get cut. So I'm also going to talk about alarms a little bit and give you a demo, and battery changes, and then how to assess a blood pressure, which is always kind of challenging. So I already talked about the no chest compressions. One thing I want to say, we've learned from experience that people can be awake with the worst rhythms in the world, and they're still literally talking to you. So we've had patients who are in, VT, with a really high rate, and they feel pretty lousy, and their pump may not even be alarming. That's how good the pump is, because it's compensating. But they are super awake. So if you were going to shock them, and just like a person who is cardioverted for a rhythm, you need to really put them out, and they need like anesthesia. They need propofol, and they need the heavy hitting stuff. A little fentanyl and Versed won't be enough, right? Especially if they're getting defibrillated. Like if they're in VFib and they're getting defibrillated, if they're totally out, that's one thing, but if they're awake, they need to be way put under. And the EDs know this, right? So that's generally where they're going to go with stuff like that. They're anticoagulated, so they're supposed to call us when they fall. They never do. If they hit their head, they're supposed to call us. They never tell us until like 3 days later. Don't want to get water on anything. And I'm going to talk more about the driveline stabilization. This is a graphic of what a person looks like with a heart pump in, but this is what you might see on their abdomen, what's coming out. And this is a very nice dressing right here. And it's secured with this, we call it a Foley anchor, because I think it was designed for Foleys, but we use it a lot to stabilize that drive line. We do not want that drive line tugged on. And this dressing is basically like a sterile dressing, very similar to what you would do for a central line dressing if you do those things as part of your practice. I have a bunch of pictures, and I'm just going to say some of them are a little, might be hard for some people to look at just because they're kind of a little, to me, a little gory first thing in the morning. So if you don't want to look, don't look. But I just wanted to show you kind of things you might see in a patient. So our patients' caregivers are trained to do the dressing, and that is supposed to do the dressing. They shouldn't be asking you to do the dressing. If they are, we should you know, reach out to us and we'll talk with them and come up with a plan. But that's an expectation of the caregiver to learn. And we do a lot of time training people and doing tests and everything before they leave the hospital. But here you
I just wanted to emphasize that, Kathleen. I thought that was really fascinating. The patient and the caregiver actually both need to pass a test before they can be discharged home from the hospital, which I thought was great and surprising. So they can be a good resource for you.
Yeah, and it's they have to demonstrate stuff, and we take them through scenarios. So we really try to get them ready. This is like someone who had a VAD implant, and you can see their sternotomy scar, and those three stab marks are from where the chest tubes were, and over to the left you can see the driveline dressing. I thought you might want to see what it looks like under the dressing, you know, because sometimes you're like, what is under there? This patient is not healing well at all. You can see there's a huge gap here around the drive line. This is actually an HVAD or heartware drive line, and they look different from the HeartMate ones, and they're hard. And so what this tells us, it wasn't well secured, and it was pulling. So that's a risk for infection, but also it's not going to heal right. We want that to close up around the drive line. So this is not good. And there's this, I think that's a stitch still in there. A lot of patients, I just want to show you, will have one of these. It's called a binder, and it's used also for drive line stabilization. So we really stress this, especially in the beginning period. And inevitably, the people who don't follow those directions have really problematic driveline infections. And those can be very, very serious and life-threatening. Here's another badly healed one. And you see this? This is actually supposed to be on the inside of the body. It's called the velour. And the inside of the driveline that's in the body has all that to help the tissue heal into it and to stabilize the driveline. And this person's driveline got pulled out, and it's also got a very poor wound healing and some necrosis there. This poor gentleman, this is Lovenox, and you guys probably see this all the time, but poor guy, but he did a great job on his dressing. And you can see he has it secured with the device here. And so this is a nice looking dressing. Lovenox bruising, we do worry about it, you know, so if that's what's going on, feel free to call us. Here's a, you know, this doesn't look so bad, but it's so red looking. And so what I've learned from working with our ID doctor, Dr. Woolston, is that this can actually be cellulitis. It almost looks like a bruise. So we're very aggressive with anything that doesn't look right and getting cultures. And you can see the velour got pulled out on this person a little bit too. So we get a culture, and we may even start them on antibiotics before we know what the culture looks like. We don't want that infection to ascend up to the heart, because there's a tunnel there. Basically, it could ascend. Here's someone who had a thoracotomy. So the good thing about the newer pumps is surgeons can use a different approach if they need to because of the patient's anatomy. Also, if the patient's going to be a transplant patient, the transplant surgeons love it when they get a pristine sternum for their heart transplant. So doing this approach, like the LVAD surgeon's always getting a lot of bonus points for doing that with the transplant surgeon. This actually looks like a pretty well-healed driveline, and this patient's very meticulous, but he actually did get a driveline infection. And even, I mean, it looks a little hypergranular here, but looks pretty good. But he's on suppressive antibiotics. And because of the type of organism he has, he's been bumped up on the transplant list to what's called status 3. Here's another really nice, well-secured drive line. And this is unfortunately someone who got their drive line dressing wet at a lake. And this is drainage. This is a Pseudomonas infection. And this is really catastrophic because it's so multi-resistant. So we are extremely worried about this patient. Very, very worried. So I was just going to discuss a little bit about the numbers, because you see over here on the right is the controller that the patient has. In the hospital, we have this whole setup and a screen and all that. But this slide is to kind of tell you that all the information you see here on the left is actually on this controller. And the patient, what I encourage nurses to do if you're new to a VAD patient, say, you know, I've learned a lot about this, but can you show me how this works? And most patients are very proud of what they know and how to demonstrate things. Ask them, can you show me your numbers on your controller? And they will push this little button here, and they can scroll through all these numbers that you see on the left. So one of them is called the flow. And I think of that as cardiac output. It's actually a calculated number on the pump. One of them is the pump speed. That's how, it's a fixed speed. That's how fast the pump is running. It's not going to vary. Okay. It's always trying to stay right around what it's set at. The pulse index is a number which is sort of additive information, which can tell us something about the patient's volume status and also their contractility. And the power, we want that number to stay very stable. If we see that power start to trend up, that could indicate a clot on the pump. So that in a nutshell is what we call the VAD parameters. Like in the beginning, I was like, what do you call these? And vital signs, but they're the parameters or their numbers. But you can always invite your patient to show you their numbers. And it's very interesting how much they know about their device.
And you actually encourage them to keep a daily log of them as well, correct?
Yes, we have a sheet. There's to write their weight, their blood pressure, their numbers, anything going on with their dressing, how they're feeling. And we look at that in clinic visit too, to look at the trends. Oops. I'm not sure. This is, I'm not going to go into these, but this is, I wanted it on the PowerPoint so you guys could click on these and get to these websites. One is the Medtronic website, which is actually the HVAD website. They have a lot of nursing education. It's a really good website. But the Abbott website is more geared, I would say, to physicians, but it's still very useful. And so I just wanted you to have these as a resource. So for alarms, alarms are alarming. Sometimes when you hear an alarm, it's like, it's so hard to concentrate. If a patient's having an alarm that so you can silence alarms, and sometimes I advise patients to do that if they call us with an alarm. It's like, okay, you're all right, just silence the alarm, because then we can, I didn't say this, but we can kind of think about it without that hearing that going off in the background. So what we advise is that for alarms, do exactly what you do for any other patient. If they are in distress, like assist them. And the most likely scenario would be that they would be dizzy. So help them lay down or sit down. You can call 911 from them if they know to do this too. They're trained on this. And then they have a card that's they have with all our contact information, and then call us if you can do that. The thing is, you can have no alarms and everything looks perfect and the patient doesn't feel good. That is a huge concern. If a patient feels dizzy or lightheaded, that is a huge concern because they can be in VT. And, you know, we've had that happen. Didn't feel good. I took an Uber over. put them on the monitor. I was like, oh my gosh, they're in VT, They weren't feeling great, but, so even VFib, people can be awake with. So, the most important thing, and I always tell this to patients and families, it's how you feel. Even if everything's perfect on your sheet in the morning and you're not feeling good, call us. And sometimes they do, sometimes they don't. So I was just going to demonstrate an alarm here to give you an idea. Sorry. Stop my. What I have here is a simulation pump that we use for teaching here. And what it is this is the controller, the pocket controller. And you can see here, there's 2 power cords. And right here, this is the drive line. Okay. Now it's pretty hard to get the drive line out, but it can be done. If you open this and push down this red button hard and pull on this really hard, you will get a red alarm. It's pretty darn loud, right? And the pump stops because it's literally not connected to anything at all. And then to put it back in, actually patients and caregivers are trained on how to do all of this, just so you know. So seat the drive line again. It can be hard to get back in, which is something we teach the team them about. So, and then what will happen is the pump will start up again and be okay. So that's what's called a red alarm. And I've actually never had a patient, no, I had one patient do this with a different pump, and they literally don't even remember doing it. We could see it when we looked in the background. But this is very rare that someone would take their drive line out accidentally. But someone did do it, and then they didn't even remember doing it, them and their husband. So that was kind of puzzling. Now, if the batteries, or let's say you disconnect all power from this HeartMate 3 or HeartMate 2, this is true of both these pumps. I'm taking both batteries off. The first battery I take off, you hear that little beep? That's like a warning alarm to the patient. Hey, you just took off a battery. The front of the screen actually has a nice user interface. It tells the patient what to do. It tells them where the problem is with that little blinking yellow light right there. So pretty user friendly. Now, let's say they just forgot and they took off both batteries at the same time. I'm going to silence that because it's just goes right through my body when I hear that. But you can see actually the pump is still running. The pump is still running because, believe it or not, there is a battery in this. It's called the backup battery. People are not supposed to what we call double disconnect. But for this particular pump, for any HeartMate pump, it has this backup battery in it, so the pump will not stop. So there's the famous story of the guy who, when he went for his clinic visit, they looked and they saw every day around the same time, he would double disconnect for like 10 minutes. And the backup battery in this doesn't last very long. It lasts like maybe 15 minutes. And they were like, what are you doing every day at 11 o'clock? So he just disconnected from everything and would walk out to his mailbox to get his mail and then go home, go back into the house and then connect to power. And, so patients will start to take risks that you wouldn't normally think they would do, but we didn't, that's like a folklore story in the VAD world, but it's very characteristic of some of the things you can discover. So we super advise patients not to do that. And then the basic heart failure self-care, which I'm sure all you guys, are doing all the time with your heart failure patients, but this is so essential. And we tell patients, you're getting a heart pump, but you're still a heart failure patient. And so you need to do all these things. It's a big job having an LVAD, and it's a big job having a heart transplant. So in some ways, I think a heart transplant might be a lot easier, to be honest with you. Most patients say they just, who likes equipment on them all the time? Not fun. So how we doing on time? Okay. About an
It
hour.
is 9:30 right now, so we've been integrating questions as we go, so I think we're doing okay.
Okay. So I want to talk about blood pressure because, these patients, like the gentleman who said to me, I don't have a pulse. Well, actually, he does. And he did. So if you took a Doppler and some gel and put it in this brachial area of his arm and listen and hunt around, you're going to find a pulse. And you may feel a radial pulse. That's one of the first things I do with a patient is I see if they have a radial pulse. And I wait a while because the radial pulse is kind of telling you the aortic valve is opening, right? And sometimes the aortic valve doesn't open every beat with patients. So I just kind of sit there and I wait a while to see if I feel that little flutter. And what we want is the aortic valve to open every 3 to 5 beats. That's how when we do the echoes, that's how we kind of gauge it. And that's because we want to decompress the left ventricle. We don't want too much in there so that the aortic valve has to open all the time and inject blood. But we also don't want the aortic valve to fuse. It needs to still be mobile. So feel for a radial pulse, may or may not feel it. And I always try a blood pressure cuff, an auto cuff, because it may pick up and it can give you some good information. A patient will usually tell you, oh, the cuff works, and they usually use this arm. Or they may tell you the cuff never works. So you say, okay, let me just try. Because sometimes it can change even from day to day on a patient, depending on their volume status. And our target blood pressure is 60 to 80, and that's the mean pressure.
And also, too, wanted to add, for those of you who may not know, we should have, I know not everyone routinely carries a Doppler with them, but each office should have one. So if you know that you're being assigned a patient with a VAD, certainly something you could request ahead of time.
Mm-hmm. Yeah. Some patients do have them at home too. The ones who are really sort of medically oriented like to have, we'll give them a Doppler and stuff if they want to do that. It can be tricky. So I'm going to show you how this video, I think, is a good one because this is an actual VAD patient. I hope you can hear all that construction. Let me see if I can shut the window while you're watching this. They're doing like massive construction outside. I hope it's not too loud.
No worries.
It always freezes here for some reason. that is definitely not easy to hear. And that can be how hard it is to hear. And so sometimes it takes me like 5 minutes to even find the brachial pulse with the Doppler. So I often will make a little mark there if I have a surgical marker to mark where it is, because it can be hard to find. Some patients know exactly where it is on their arm. They'll be like, oh, you just need to move a little over to the left. They'll get it. So it's amazing how much these patients know. But so this is one way of assessing the blood pressure, right? But then you have a cuff too. So what does all that mean? So number one, I always believe my ears. So if for some reason the cuff is giving like wacko numbers, I just put that aside, because the cuff is not going to be as accurate as the Doppler, and it measures a different way, okay? But it's good to do a cuff with the Doppler because it can give you an idea of what you're measuring. So this was actually a patient, this was our first patient again. He stuck out in my mind for all these different reasons, but he came in, he was admitted, and I don't actually remember the reason he was admitted, but we were trying to get his, vital signs and all that. And we used the Doppler and we got his map, and it was like 120. And we were like, oh my gosh, his map is 120. That is ridiculously bad. Have you been taking your medications? What is going on? So we started giving him hydralazine, and it wasn't really coming down much. And we were like, trying to assess why would this happen with this patient, right? And then I'm trying to remember how we figured this out. I think it was Dr. Shao said, put the blood pressure cuff on him. So we put the cuff on him, and his cuff pressure was 117/84 with a map of 95. So what we actually had been measuring with the Doppler was his systolic blood pressure. Now, granted, the map of 95 is not great, right? It's too high, but it's a whole lot better than 120. So sometimes if someone's what we call pulsatile, and you do a Doppler, what you're going to be measuring is their systolic blood pressure, not their map. So you have to be a little bit of a blood pressure detective. In general, if I have had patients that I literally cannot get a blood pressure on with a cuff, and it's really hard with the Doppler, but they're perfectly fine. If the patient doesn't feel well and you cannot get the Doppler and you cannot get the cuff, that to me is a pretty big red flag. But some patients honestly will tell you the cuff never works on me, never. And we've gotten to know those patients pretty well and where we can Doppler them. So I did have a patient once, this is the lady who had the aortic regurgitation. I was working as an educator, and someone asked me just to check her map because, we're helping each other out. And I went in and I could not hardly hear it, and then I did it again, and I did it down the other arm, and I was getting like 40. And I was like, am I doing something wrong? Because I wanted someone to check it. It really was 40. Sometimes I'll have someone double check it. But I just thought it can't be 40. She's sitting here talking to me, but it was, and she ended up going to the ICU. So that is my little piece on the Doppler pressure. This is just a note about the resources. All our patients, we're open 24/7. But just so you know, we don't take care of every bad patient in Maine. Some patients are managed through the Brigham, through Tufts, or through Mass General, if they had their implant in Boston. This is a list of some of the complications, and I've already kind of mentioned these just in going through all this. Device malfunctions are rare, but they can happen. Right heart failure, we really try to you know, everybody has some degree of right heart failure getting an LVAD because they've had such bad heart failure usually for so long. But we don't want the pump to drive the person into acute right heart failure. So that can be a real problem. So we're very careful in our workup. And this is just a clinical pearl that I do think the patients are amazing. You get to know them so well. Their caregivers are amazing. They're very strong people. We always have a big celebration here when one of our patients gets a heart transplant. So it's just a very joyous thing. This is the card we give the patients, and they have all our contact information on the other side. And this is our contact information here, which I'm always happy to answer questions if I can, or find resources for people that might need them. And I think that's where I was gonna stop and see about questions. And
actually, we wanted to, I'll do that, the final poll, if we will, and then we can break into questions.
Okay, great.
So I've got another little poll just to kind of reinforce some things that we've talked about. Hopefully you guys should be able to answer easily here. I'll launch that now. Okay, we'll go ahead and end them here. I'll share the results here. Kathleen, again, feel free to pipe in here. So for question number 1, some appropriate topics to reinforce. Pretty much everything except for, you may recall that we really don't want patients to be performing CPR on a patient with a VAD unless you're directed to by a physician. So that might be the one exclusion for that. So the interval for a driveline dressing to be changed. The answer we were looking for was to accept under special circumstances, the driveline dressing should be changed daily or every other day, depending on the provider's orders. The standard fluid, yep, go ahead, yeah.
I would say that is characteristic of a patient who's a fresh implant. So in the beginning, as a fresh implant, there's a lot of drainage over time. And so the caregiver is trained to do the dressing, and oftentimes they have to do it daily for even more than a month, maybe a couple months. And then as time goes on, they can space it out to every other day, every 3 days. And then once everything's pretty much healed up, they can go to what's called a weekly dressing, and they may be able to change it once a week. So there's a large variety of variation in that. The other thing is, if a patient's having problems, we're probably asking them to change their dressing every day. If they're having like an infection issue, because like when I showed you that drainage from before, that can't sit on the wound, it has to be cleaned off.
Great, thank you for that clarification. The standard fluid restriction for a patient with an LVAD in liters is 2 liters is the answer we were looking for. And the last question, the main complications that a clinician caring for a patient should expect, pretty much all of those. The infection, pump thrombus, hemorrhage, suction event, arrhythmia are ones that could potentially happen. So I'll stop sharing those results. Yeah, go ahead, yeah.
I explained suction event very well, so I will do that now if that's okay.
Yeah, go ahead.
So what can happen is what we call a suction event is the pump is running continuously and it's a fixed speed, okay? And so it's not going to vary itself based on the patient volume or the patient exercise or activity level. It's always going to run the same speed. But the problem with that is that if, let's say, a patient got super dehydrated, which can happen, right, with all our diuretics, or they're bleeding a lot, like they came out of the OR and they're just bleeding a lot, the pump will keep running and keep trying to pump, even if there isn't a lot of blood flow to the left side from the right. And so it will actually keep sucking so hard that the walls of the ventricle, it's called a suction event, come down like that. And what happens is the patient has a lot of dysrhythmias usually. Strangely enough, some patients don't feel it at all. It's just, but generally speaking, people are going to feel that. They may have rhythm disturbances because the ventricle is getting irritated by all that motion and being sucked down. So the wonderful feature about the HeartMate is that computer that is the pocket controller that controls everything, it can start to see that happen in the background. And what it will do is slow the pump up. So remember I said the speed is a fixed speed, it never changed. It never changes. It could change if the pump is starting to see a suck down. And what it will do is slow the pump up in order to give extra time for the ventricle to fill, so we don't get a big suck down. So that is called a suction event. They don't really happen that much, I would say, but we're always on the lookout for them. And you really wouldn't be able to know that's going on with a patient in this, like the patient might just say, I feel dizzy. And so that's what could be what's going on, you know, and then we have to do some assessments on it.
Okay, great, thank you. So we've got about 4 or 5 questions. We have about 10 minutes left here. So I'll do my best to try to get them ticked off here. So the first one I have on my list is from Steph Lagar, who's a wound nurse. And her question was, are there any issues with pressure injuries with an abdominal binder over the hard tube?
Yeah, good question. There can be. So because that drive line can be pressed into the skin, that's more where you might have an issue. If you don't when you do the dressing change, we encourage caregivers to not always use the same spot that they're bringing the drive line out of the dressing. And so we haven't seen serious pressure injuries from the binder, but if we start to see pressure of any kind, then we usually counsel rotation of the drive line to a different area. The binder, people really don't like it, but we do advocate it in the beginning at least.
And I do want to address too, I know we have some physical therapists and occupational therapists in the room, and there are some questions on that topic. We do have a handout that hopefully will address maybe some questions you have, but because we've got some time, I wanted to discuss, could you speak to typical post-op activity recommendations or restrictions that these patients may have?
Yeah.
What should PT and OT keep in mind when they're working with these patients?
Thank you for mentioning that question, because I meant to bring up, people are in a lifting restriction. It's usually 8 pounds. You know, we advocate very, very strongly that there's no heavy lifting in the beginning because everything's healing up inside. All right. We've had patients forget that and do things like lift car batteries. Not a good idea, right? It's going to mess up healing. Over time, those restrictions can be changed, you know, as people get stronger and more conditioned. They can lift more. Our doctors usually, you know, liberalize that. In the beginning, when people first go home, the first 30 days, we have a caregiver stay with them 24/7, someone who's trained. That's something we require to implant an LVAD. And the reason is they're vulnerable to falls. But once they're strong enough, we would like them in a non-COVID era to do cardiac rehab. I know cardiac rehab is kind of a big question mark right now, but generally speaking, we have home PT and sometimes OT, depending on what the patient needs, and the home health nurse that first month, because they're homebound. What else on lifting restrictions? So I actually have a good article I'm going to send to Rob that has there's a study going on right now, PT/OTs, about exercise in beds, and I think it's going to be a good one. So I'll send that off to you. I don't think it's going to be a good study, but it's not resulted yet. But I know we have great therapists here who are really experts in the bad patients, and they use the Borg scale, which I think is like a perceived exertion scale when they work with patients to modify activities in the initial post-op period.
Great, thank you. Next question I have is, are patients educated on bathing and showering post-op? What might that look like?
Good question. Yes, because we don't want it to get wet, right? But in the beginning, they're doing little, you know, partial baths. They cannot take a shower until we clear them. And the criteria for that is that their driveline dressing is healed up and not draining. Once that happens, and it can be months, we train them to take a shower. There's a special bag that we train them to use. We have them set up and clean their shower, like even soak the shower head in a light bleach solution, because of all those water bugs being so problematic if they were to get into something. But we give them big tegaderms to cover their dressing, and then another, and some people put saran wrap after that. And then there's a special bag that protects everything from water that they can hang on a hook. And they sit down in the shower, and they got a handheld, and they shower. So it's a big deal. Yeah.
So there were two questions talking about the mean arterial pressure calculation. One of our PT, Stacy, had mentioned that the calculation is mean arterial pressure equals 2 times the diastolic blood pressure plus the systolic divided by 3. Is that's correct? Yep.
Right. And you'll see sometimes with an auto cuff, that may come up with a slightly different mean arterial pressure than if you do the calculation, because it just calculates it a different way. It's fine to use the mean arterial pressure on the auto cuff if you have that function. Okay. But a lot of auto cuffs at homes don't have that. So we teach the patients that also.
Heather Pond, do you know, I believe our telehealth cuffs do register mean arterial pressures, don't they? If you're on right now, I'm not sure if you're doing other stuff.
Oh, sure, if they're.
I don't think they do, or I don't think they do.
Okay. I wasn't sure about that. Okay. And the last question I have is, I think we got 4 minutes left here. Do you know if poor dentition or caries would exclude someone from implantation due to increased infection risk?
A great question. So part of our workup is that we do a Panorex on people, and if they haven't seen a regular dentist and they have a lot of caries and stuff, they've been known to have extractions before their implant. If we do want all our patients to have good dental care. So if someone's being worked up and they haven't seen a dentist in a year, even if their Panorex is okay, we're like, please go see a dentist. You need to get, because, the oral health is so important to the rest of the body. So we've never not implanted somebody because of their dentition, but we have had people who had many teeth removed, sadly, because they were in such bad shape and we couldn't risk putting the pump in with them like that.
The next question we have, I think we can squeeze in before we wrap things up. At home, our patients set up with a supply company for dressings, and I believe you guys supply the dressings, correct?
No, actually we do. We work with a Celis to supply dressings. However, some patients for insurance reasons can't get a Celis, and we work supplying them actually. So, but the majority of our patients, we work with a Celis for ordering supplies. Yep.
Okay. They keep trickling in here. One final one. What are some reasons people would not qualify for a transplant?
Mm-hmm.
And Lucy, were you talking about a heart transplant or a VAD? I presume you're talking about a VAD.
VAD and heart. Well, mainly a heart transplant.
Okay.
Yeah, heart transplant. That's a tough one. So, their kidney function has to be good. So if they've not have good kidney function, then they, it might be like a heart kidney, which seriously reduces their risks of getting an organ. Liver. If they are using substances or toxic substances they need to be 6 months free of nicotine and any toxic substances. And so we screen them irregularly to make sure that they're not using drugs. The other thing is, so the other organs are important. Infection, if they have a really bad infection of their drive line and it's going up, it can affect the tissue in there and they may not want to implant that person. Lung function, if lung function isn't good, so those kinds of things. Think of anything else. So they need to have a certain amount of social support, just like for our patients. And we work really hard with patients and families to try to get that to work. But if someone has absolutely zero social support, it's not going to be a successful venture, because we know they need that to be successful. So that can be pretty tough. We have a guy who's homeless, who just, he's on a Milrinone drip right now, being homeless. But he's not a bad candidate. He just doesn't have any social support. We have social work involved. We do our best, but some patients, it's just not going to work. It would be a disaster were we to give them a pump.
Well, thank you, everyone. It's now 10 o'clock. I really appreciate you attending. I hope this has been helpful and informative. We will be getting you some handouts that take a bit of a deeper dive on the subject. As Kathleen suggested, if you're a therapist, there's a discussion on that study. We'll get out to you. There's also a continuing education activity available in HealthStream that does discuss VADs in a bit more in depth. And lastly, too, here, I'll be posting a survey here through email, but also I'll post it to you all here. If you could take some time to fill it out, we would greatly appreciate you taking the time to fill that out. Thank you so much for your time, everybody. And Kathleen, we really appreciate your time and expertise.
My pleasure. Thank you guys for all you do. You're amazing. Thank you, thank you, thank you.